Hello, everyone. It looks like we are live now. And welcome. I'm Jonathan again with the Institute of Human Anatomy. We are going live with some discussions on muscles and, of course, your live Q&A questions. Just some quick updates. Nothing huge going on here except making videos, content, things of that nature. We were supposed to have our part 3 of the female reproductive series drop yesterday. We are not having, well, we're having a little bit of a technical difficulty with it with YouTube, and so Justin is in the process of working on that now, so hopefully we can drop that soon. Other than that, just kind of picking up where we left off last week with our last live stream, and people are joining in now and getting some questions. But I was just thinking of the topic to talk about this week, and it's always hard because there's so many topics to discuss, but it just came up that muscle tissue just came to mind because I had some discussions with people about exercise, working out, and it's really a cool concept to think about that there are actually 3 different types of muscle tissue in the human body, and that's what we want to go over and just jump into now. So some of you have probably taken an anatomy and physiology class and gone over this, but most students, when they review this stuff, they learn something new. So even if you've gone over this before, hopefully there's some new cool information that you get. So let's first just kind of have this little bit of discussion. Muscle tissue, what is it? Muscle tissue is a really specialized tissue that shortens or contracts. If you guys think about that from a physiological perspective, a lot of you have probably taken classes when you've learned about the cell. And when we first talk about the human cell or a eukaryotic cell, you've heard about things like there's the nucleus, there's mitochondria, endoplasmic reticula, all these different things like lysosomes and peroxisomes. And you learn all that basic cellular anatomy, and you can apply that to other specialized cells like muscle cells, neurons, which are nerve cells. And muscle cells, when you get into specialized cells, yes, all of these cells have things like a nucleus for the most part. There's some exceptions. Mitochondria, lysosomes, peroxisomes, endoplasmic reticula, all those fun things you remember in biology. But then they also have their special, unique things that make them really cool and specialized, especially a specialized cell like muscle cells. Now think about this, you guys. There's not a cell on the body except for muscle cells that can go from its resting length to half of its size in a split second. I mean, think about how amazing that is. A cell can go from here to here in a split second. If you think of Usain Bolt, a cheetah, how fast those cells are shortening, lengthening, shortening, lengthening. I mean, just to do that, I had to shorten and lengthen cells. So it's pretty amazing. And we are trained to think about muscle tissue when it comes to like skeletal muscle tissue, but that's only one of the types. The 3 types are cardiac muscle tissue, skeletal muscle tissue, and smooth muscle tissue. But why did they get those names? And a lot of people actually have heard things like this phrase called striated. And technically, skeletal muscle is called striated skeletal muscle. Cardiac muscle is technically called striated cardiac muscle. And then smooth muscle didn't have striations, and that's why it got called smooth muscle. And to give you a little bit more ideas on that topic is when they looked at these muscle tissues under the microscope. So when they look at these muscle tissues, literally just think about taking a biopsy, which is a tissue sample, say like the biceps. A tissue biopsy of cardiac muscle tissue and a biopsy of smooth muscle tissue, say like in an organ. And you look at it under the microscope, yes, the cells had some similarities because they had these contractile proteins that could shorten and contract, but they also had some differences. And skeletal and cardiac look striped, how the light microscope hit it, and it looked like, and they called that striations, and striations just refers to striped. When they looked at smooth muscle, it was lacking those striations or that striped appearance under the microscope. When we edit this, I think Justin and I can throw in a little snippet of just some pictures here, but it didn't have those striations, so it looked smooth. So those are the main things why they got named differently. So skeletal, cardiac, and smooth. They look different under the microscope. Now, a lot of students, when they learn about these muscle tissues, also learn about voluntary versus involuntary. And when you talk about voluntary versus involuntary, some of that muscle tissue is under voluntary control, meaning you can control it on demand when you want to, versus involuntary, it just works on its own automatically. And if you think about, okay, which one's voluntary, most people have a pretty good idea of, yeah, I talk with my hands a lot, as you guys can see. I'm initiating skeletal muscle contractions voluntarily. So skeletal muscle is under voluntary control for the most part. There's a few exceptions like the diaphragm. Muscle cramps and spasms are obviously a little bit of an exception to that. But for the most part, we control the skeletal muscle activity. And most people have a pretty good idea that the cardiac and the smooth muscle is under involuntary control. And I'm going to show you guys some examples on the cadavers. If you can see this little white sheet right here, we've got some, I guess, white plastic. I'll show you 3 examples of those things in just a second. So, but back to this voluntary versus involuntary thing. Cardiac muscle is considered involuntary. And I've had plenty of students kind of argue with me on that as far as, okay, is cardiac muscle voluntary? And I look them in the eye and I say, make your heart beat at 62 beats per minute now, go. And they kind of, and they get the idea. You know that if you go running down a hallway, your heart rate's going to go up. You know, if you do deep breathing and meditation, the heart rate's going to go down. So you have this kind of involuntary, or I should say indirect control to a certain degree, but you can't make it beat and stop just like you can snap your finger whenever you want. And obviously, we never want to voluntarily make the heart stop beating, and which luckily we can't do. And the other type, smooth muscle, again, involuntary. I want you guys to think about that. When people think about smooth muscle, it's in the walls of your organs. And so I just want to kind of step back for a second before I show you the cadaver stuff, and then we'll go into some more detail here, is that I always tell students, okay, we've got these 3 classifications: skeletal, cardiac, smooth. Where do you find them? Well, skeletal muscle tissue got its name because it attaches to and moves the skeleton. And we're so used to that, we can always find our skeletal muscles: biceps, triceps, quads, hamstrings. When you think about muscle tissue, you typically think about the skeletal muscle tissue that voluntarily moves your skeleton because it attaches to it. Cardiac muscle tissue, if I ask students, where is it? Most will say cardiac means heart, so you just find it in the heart. True. Smooth muscle is a little bit more broad, and we generally say it's in the walls of your organs. And I take it a little bit further with students. I say if it's a tube, it likely has smooth muscle in the wall. And think about that. When you think of tubes, I always think about like a hose or something like that. But we are full of tubes, like your blood vessels, tubes. In the wall blood vessels, there's smooth muscle. Your smooth muscle can vasoconstrict and vasodilate. Your trachea, your bronchial tree, it's a tube for air, smooth muscle in the wall. Ureters, which take urine from the kidney to the bladder and the urethra, all these structures have smooth muscle in it. And I mean, we can go further. Obviously, the digestive tract has smooth muscle. And I want you guys to be really kind of, I always say to students, be really, really grateful for that moment that like you don't have to think about contracting around like an S curve of your jejunum to move an Oreo cookie through there. You'd be like having to move it around and voluntarily think that would be a pain to think about that. So luckily, that's under involuntary control. On the other note, I always tell people to be very, very grateful that the very, very beginning and the very, very end of the digestive tract is under skeletal muscle control. Yeah? Were you thinking about that? So could you guys imagine if your external anal sphincter was smooth muscle and it just released whenever it wanted to? That'd be horrible. Luckily, the sphincter at the end is skeletal muscle. That's my 12-year-old boy sense of humor. But moving on from there, hopefully that gives you guys some ideas about that. And I'm going to show you the cadavers, but I have one other thing that's super cool. So let me just do this. When you talk about muscle tissue, you talk about muscle cells or muscle fibers. And I want you guys to think about this idea of how you get bigger and stronger with skeletal muscle tissue, even cardiac muscle, and smooth muscle tissue. And so let me just show you guys, let's just go to the cadaver and we'll have this discussion as we go here. Okay, so we have 3 examples of where you can find different muscle tissue. So right here, you guys can see this is a heart, and then this is a calf muscle, the gastrocnemius, then becoming down to the Achilles tendon here. And over here is the stomach and the beginning of the small intestine. I'll show you in a minute where we're showing there, but in the wall of those tubes, you're going to see some smooth muscle. Now, just kind of coming up close here, you guys can see the cardiac muscle. Now we've removed the outer layer of the heart, which is called the epicardium. It usually has some epithelial lining and some fat there. But this is all the myocardium, all the cardiac muscle of the heart. You can even see how thick the wall is in this left ventricle right here. So this is really important because these are those muscle cells that do the majority of the work for the heart. These things are going to contract and milk the blood in and out of certain chambers. And so really important muscle tissue there. You can see this is just the wall of the right ventricle, a little bit thinner. So one example here. Now to the naked eye, they look kind of similar if you think about the skeletal muscle versus the cardiac muscle. And these two look the most similar under the microscope when you compare it to the smooth muscle tissue. But if you look closely, you guys can see the fiber orientation of those skeletal muscle cells. And that's one thing I want to mention real quick, and I'll just talk to the camera with this one. When you guys talk about muscle tissue or muscle fibers, all of us have probably heard that phrase, I got muscle fibers or exercising muscle fibers. Muscle fibers is synonymous with muscle cells. And so what you're seeing on those, the strings there, you can see, or the string-like nature there, or that fiber orientation, are all the muscle fibers going in that vertical direction that we're seeing in this particular muscle. And so skeletal muscle cells is the same thing as skeletal muscle fibers. Now this one's a little trickier to show. I'm going to find the little area in the wall where we cut here, and let me just pull this out. You guys get to see guts as well as smooth muscle tissue here. We're going to find it here. There it is. So here's the inside of it, but I'm going to have to get you really close to the camera here. We're going to have to get this thing to autofocus for us. There we go. Come on, autofocus. Okay. Focus. So if you guys can see, it's kind of a darker line there, right along there. That would be the smooth muscle layer, that darker line in the wall of this tube. Now, this will be for another discussion, but the surface area that you get with the inside of the intestine. But that smooth muscle is in the wall of that tube, so it can, again, move and propel food down the food tube. Now, since we've been doing the female reproductive series the last little while, one thing that's really interesting about that is the largest smooth muscle in the human body is the uterus. And that is technically a hollow tubular organ as well, but really powerful organ if you talk to most females about how hard that thing can contract. One of the things that is super awesome about it, or kind of interesting to think about, because I asked, think about getting stronger. Cardiac muscle cells and skeletal muscle cells cannot divide. So I want you to think about how important that is for, and kind of from a functional perspective. If skeletal muscle cannot divide, how do you get stronger? How do you get bigger like Arnold Schwarzenegger or Lou Ferrigno? I know those are the old school guys, so if you guys are in the younger generation, go look at some of those old YouTube videos of the bodybuilding and Mr. Universe competitions. Anyway, how do you get stronger? And from a clinical standpoint, what happens if you kill skeletal muscle fibers or cardiac muscle fibers or cells that can't divide? So think about that from a functional standpoint. So one, how do you get stronger? I'll give you the spoiler alert. The cells that you have in skeletal and cardiac muscle tissue just get bigger. It's called hypertrophy. Hypertrophy is just a cell getting bigger. And when the cell gets bigger, you have more contractile proteins inside the actual muscle cell, and therefore it can produce more force, and then therefore create more weight, speed, whatever type of exercise or activity you're doing. In the case of the heart, those heart cells can get larger and therefore contract more forcefully, more effectively. Athletes tend to have slightly larger hearts in a good way. There's physiological enlargement of the heart, which is a good thing. And then there's also pathological enlargement of the heart, which is a bad thing, in which we can talk about congestive heart failure and things of that nature in a later video. So again, but from a perspective of just, okay, that's one thing, I can get stronger, but what if they die? Think about if your cardiac muscle cells die. You can't replace them. And so that's why a heart attack can be so detrimental. You cut off the blood supply to the heart. Some of those cardiac muscle cells die. If you can't replace them, it gets replaced instead with non-functional tissue that can't contract, which is scar tissue. And so, again, very detrimental. Same idea with skeletal muscle tissue. if you kill some of that muscle tissue, you can't regenerate it very well. There is a little bit of an exception of skeletal muscle tissue because skeletal muscle tissue has a few stem cells kind of hanging out in there, even in an adult. And you can create a few more muscle cells in really severe injury or where a whole bunch of muscle cells die off, but it can't, there's limitations to it. You couldn't replace like a whole muscle. If you say you like killed 30% of your muscle cells in your biceps from some crush injury that cut off the blood supply to the whole biceps, you couldn't actually replace all those. You could replace some. So there's some minor or mild regeneration because you have some stem cells in there, and those stem cells get forced to become new skeletal muscle cells. But once a stem cell becomes a full adult skeletal muscle cell, it's there to stay. It can't divide. Now, that's just cardiac and skeletal. I'm going to get to your guys' questions here soon. Smooth muscle can divide and also get bigger. So remember, the word for a cell getting bigger was hypertrophy. For a cell to divide, in the case of like smooth muscle cells, we call it hyperplasia. So let's use the uterus for an example again. The uterus undergoes amazing changes when you're talking about pregnancy. The size and the amount of muscle tissue that is, I guess, created from pregnancy is awesome. It's crazy to think about. How does the uterus get that much bigger to accommodate a fetus or baby and then have enough force to push that thing out the vaginal canal? Maybe I shouldn't say thing, but the cute little, whatever you guys want to, baby, fetus. I'm stopping now before I dig myself in a hole. But you guys get the idea. And so what happens is those cells, those smooth muscle cells of the uterus start to divide. That increases the size of the uterus, but they also increase in size. And did I say number? Let me just rephrase just in case I said that wrong. They increase in number, which increases the size, but the cells also will get larger too. So the uterus or smooth muscle can do both, hyperplasia and a little bit of hypertrophy. Pretty amazing to think about. So hopefully that gives you guys some interesting ideas on skeletal muscle tissue, cardiac muscle tissue, and smooth muscle tissue. So let's just go to your questions here. So first question I came across right here is, we got, please talk about muscle knots, trigger points, knots, and myofascial syndrome. So Stacy, so I wish Justin were here. Justin was going to come do this session with me today, but he has responsibilities. He's got a wee little toddler running around his house that he needed to take care of, but he'll be here next time. The reason I mentioned Justin is because he did some videos and a ton of research on knots and things of that nature in especially regarding massage therapy. Now in cadavers, we have not been able to be like, oh, that's a knot right there. You can't really visualize it on cadavers and see where you're actually dealing with that feeling or that tension in the muscle. And there's a lot of debate from, are knots a real thing? Are trigger points a real thing? I think people would all at least subjectively say that you can push on a certain muscle and you can feel that radiate to a certain area. I personally can push on some certain areas of my trapezius and feel it radiate to the front of the head. Now, can you find them structurally in a cadaver? Not really. That doesn't mean people don't experience that radiation when you push that on those certain points. Now, in muscle tissue, there are connective tissue wrappings around that. If you saw that calf muscle or that gastrocnemius, there's the fascia that wraps a group of muscles, and then there's something called epimysium that wraps a muscle. And then what happens is those muscle cells, there's a smaller wrapping that wraps a bundle of muscle cells, and then there's another connective tissue wrapping that wraps one muscle cell. The reason I get that, and this is, it's nicer to have a visual aid, like a picture to show you guys this, but if you kind of think about that, I mentioned 4 connective tissue wrappings that are wrapping muscle cells. And all of those connective tissue wrappings have collagen in it. And we've talked about potentially with those collagen fibers from multiple layers potentially getting tangled together to kind of create that tissue or that knot sensation when somebody's rubbing on somebody's back or doing a massage, and it kind of feels like the tissue's binding together. That in a cadaver lab, I've actually been able to kind of see, we call it the fuzz in between like muscle tissue, between 2 muscles that are sliding against each other, or fascia on top of muscle. I'll pull that connective tissue away from the muscle, and there's like this fuzzy, like kind of collagen connective tissue that's kind of adhering between the clear connective tissue on top and the muscle underneath, and we call it the fuzz because we'll run our finger underneath it and kind of separate it. We kind of think of that as like exaggerated area where there's more myofascial adhesions potentially between the fascia and the muscle underneath. And because of that, the muscle can't slide and glide quite as effectively against each other potentially. Scar tissue is a really good example of this, kind of an exaggerated example of this, where I've seen connective tissue just fuse to muscle. And like I've had to cut it off with scalpels. One of our cadavers had a partially ruptured Achilles tendon, and the connective tissue that was on top of it just fused completely down to it. So this muscle that was trying to slide and glide underneath this connective tissue was stuck to it, so it would yank on it every single time. Probably caused a sensation of tightness and maybe even a little bit of pain. That's going to be a great video to do in the future, to have graphics and things of that nature. But that's a really good question. Hopefully that gives you some answers on that. Jorel Castro, what does it look like when we have sore muscles? Visually, to the naked eye, it doesn't change a ton. And sometimes you can get a little bit of vasodilation of the muscles. I hesitate to say inflammatory just because it's kind of a natural process. If you were able to look at somebody's muscle right after they worked out or a day after they worked out under the microscope, and they've done studies on this where I remember reading a study where they had these sprinters literally sprint as fast as they can for 100 yards, and then they'd dive on a mat, and they'd hurry and cut in and do a biopsy to take a sample of the muscle tissue right after the run so they could analyze it underneath the microscope. They were doing that study for more of like anaerobic metabolism versus aerobic metabolism. But if you could look at it under the microscope, you might see little micro tears or again, it depends on how severe, or I shouldn't say severe, how intense the workout is. You could see potentially little breakdowns in the contractile proteins of the muscle tissue, potentially, and that over time just builds up and you start to repair that, and then you also start to create more, hopefully, with the proper diet and training. So if you've ever seen underneath muscle, there's these proteins called myosin and actin. They're these main little proteins that ratchet on each other to help the muscle cell shorten. Those could potentially be damaged, again, depending on how intense the workout is. I would say that you have a vasodilatory effect, and that's where I kind of have this hesitancy to say inflammatory, because inflammation causes a little bit of vasodilation, because what's trying to happen is the muscle tissue is trying to be built up and repaired from a potential workout. And a lot of people will experience like a pump, like in their pecs after like a major chest workout, like the next 24 hours, their tissue almost feels a little puffy because there's that vasodilatory effect to get more blood flow for muscle repair and muscle rejuvenation or regeneration, you could say, to build up what was potentially broken down and even build up even more than the person was initially. Now, strength increases do take longer than just one workout, but that's the idea. Little minute increases over time will pay dividends. This will be a relatively fast, easy question. It's Sadia, what is the structural unit of skeletal muscles, sarcomeres or myofibril? Most books will say the sarcomere. The sarcomere is the functional contractile unit of the skeletal muscle. This would be really awesome to have pictures, so I'm going to try to, when we edit this, throw some pictures in here. The sarcomere is this structural unit of protein, and that, for those of you who haven't seen the microscopic views of muscle tissue, that answer might not make a ton of sense to you, but let me give you guys this will kind of give you an idea. Think of a whole muscle like the gastrocnemius or the calf muscle or the bicep. One whole muscle is made up of a whole bunch of muscle cells or muscle fibers. One muscle fiber, so we're going down from one whole muscle made up of multiple muscle cells, but then you just take one muscle cell or muscle fiber. That's made up of these things called myofibrils, and take one myofibril, and that's made up of multiple sarcomeres. And the reason I don't like to, there's a reason I actually prefer to call muscle cells rather than muscle fibers, because a muscle cell is made up of multiple little myofibrils, which translates to muscle fiber, which technically is a part of the muscle cell. That's neither here nor there. I don't want to go too far onto that. But question, I don't work out more than once or twice a week. Do I need to have a high protein diet to keep muscle tone? Yes, I guess it depends on how much you mean by high protein. There used to be in the bodybuilding world back in the day, there was like 1 gram of protein per pound of body weight, and they've shown in research is excessive. It's not going to hurt you, but it's overkill. I always tell people that you need to have both. You need to have the stimulus and you need to have the diet. So some people have said, if I just eat high protein, am I going to maintain my muscle tissue? Maybe to a certain degree, just based on the activity you do from day to day. But you also need a stimulus. So say you built up to a certain level of muscle. Usually to get to the strength, it takes a little more to get there, but there's a little less required for just maintenance. So you can have less frequency of workouts to maintain strength than you would to say fully increase strength. And the maintenance is the going to the gym, the stimulus. So if you were to go and do a full upper body workout once a week and a full lower body workout once a week, that would probably be enough stimulus to maintain your strength, assuming that you are still lifting the same amount of weights and still, while you're there at the gym for those 2 days, putting good work in, not, walking around like a toddler looking for a neck machine or something like that. I don't know if you guys have ever seen Ryan Hamilton, a really, really funny comedian who does a really good skit on the gym and neck strength. And then you also need to have the protein. So that was the origin of the question. I wouldn't say you need to be excessive. I would say, I think it's about 0.8. Let's see, 0.8 grams. It's about, you could probably maintain it with half of, like if you were to do, I usually tell people I prefer the 1 gram per kilogram of body weight rather than 1 gram of protein per 1 pound of body weight. 1 gram per kilogram is probably great for most people as far as overall body weight. And again, it also depends on who you are, how much you're breaking down proteins, what your other macronutrients are. But that's the best I could do as far as a generalized answer that you'd probably be fine on with that much protein. Okay. Question, how does endurance training affect muscle tissue over time? This looks like it's casing 2929. It's a really great question. Endurance training tends to train more of what we call your slow twitch muscle fibers. And some of you may have heard of that before, where you go slow twitch, fast twitch. So slow twitch muscle fibers sound kind of how they are. They contract more slowly as opposed to the high-end fast twitch muscle fibers, which contract more forcefully. There's always a trade-off in the land of biology or in the land of anatomica. If you get really good at one thing, you're not so great at the other. For example, the fast twitch muscle fibers are the biggest, the most powerful, the fastest, but they gas out sooner. They don't have as much endurance, whereas the slow twitch muscle fibers, they aren't as large. They don't tend to respond as well to like heavy weights. They don't tend to hypertrophy like the fast twitch muscle fibers do. And they're not as quick to contract, but they can go forever. When you think about, I shouldn't say forever, they can go for a long time. When you think about endurance runners, if you've ever seen pictures of, say, an elite Olympic marathon runner and then an elite sprinter, and you look at their thighs, you see what's going on there. There's a huge difference in fiber type that is being trained in that. And so when you do endurance training, yeah, those slow twitch muscle fibers can get a little larger, but they don't tend to do it that way. You're tending to do more repetitive, like long repetitions over and over again. They modify more physiologically by creating more tiny little capillaries, so more efficient blood flow. They also increase these little cool organelles called mitochondria, which mitochondria are great at utilizing oxygen and converting it to the energy source of ATP. And so those are some of the physiological responses that happen in slow twitch muscle fibers over time. Now, if you've never been introduced to this whole fast twitch, slow twitch thing, every single muscle that you think of in the human body, if you were to take the biceps, the quads, or anything, and again look at them under the microscope, yes, those are all skeletal muscle cells or muscle fibers, but some of them are classified as fast twitch muscle fibers, slow twitch, and there's actually an intermediate group as well, but we won't go into too much detail of that. So endurance training, physiologically, more mitochondria, able to utilize oxygen, and also lactic acid clearing. They get more effective at clearing lactic acid and dealing with increased acidic levels. Fast twitch muscle fibers tend to respond by getting larger and more powerful. So some kind of, and it never exists fully in a vacuum. It's not like you will only exercise your slow twitch muscle fibers when you're running or like doing a jog, and same with sprinting. But you do tend to be more biased to that. I tell people this example all the time. I play a lot of basketball. Basketball is inherently more fast twitch than it is slow twitch. Guys who love to accomplish the goal of dunking a basketball. And so the mechanisms of jumping is very explosive. And I had a friend who is my height, and we could both jump pretty well. And so I remember we were dunking the basketballs and stuff like that. And then he got it in his mind that he was going to start running marathons. I'm like, okay, cool, do the marathons. It was kind of funny, actually, because he was not a huge leaper, but he could dunk a mini ball on a 10-foot hoop. He was about 6 feet tall. And after 3 months of running marathons, he could barely nick the rim. He could run around at a certain pace on the court all day long. But as far as his explosive power to sprint and to jump, it was crazy because he totally shifted his focus to long distance training, and his fast twitch muscle fibers got kind of neglected in a way, and he really focused his training on the slow twitch. So Caitlin Nye, I got chronic knee pain. I was tested for arthritis as a kid. Nothing came up. Any reason for this? So I guess you're saying you didn't test positive for arthritis, which would be kind of rare as a kid. I've had some young people in their 20s get rheumatoid arthritis, but that's also somewhat uncommon. And knee pain there's so many potential causes for knee pain. It would be hard to really give you like a clear picture of what I would think it is without asking you more questions or kind of, like in a clinical setting. But young knee pain can be anywhere from growing pains to Osgood-Schlatter, which is inflammation of where the patellar tendon inserts into the tibia. There can be things where it's connective tissue related, gait related, as far as like what's your gait like, what do your feet look like? Do you tend to walk laterally rotated? Do you have flat feet? There's a lot of things, especially if there's no acute injury. I always feel like injuries are easier to diagnose than insidious or like this kind of creeping chronic knee pain, because injuries are like, oh, you twisted your knee, this ligament got overstretched or pulled, or you tore a meniscus. And it would be interesting to see your x-rays to see like if their joint space is narrow, but then again, that would imply arthritis. And so it would be hard to give you a definitive answer without getting more information on your current case. So we have some posts that you could probably give us some more information on that on our YouTube channel if you want to try that. Rumen said, can you talk a bit more about the muscles around the knee? We are going to do a knee series soon, and so that'll cover a lot of those as well. But the main muscles that support the knee are the quads and the hamstrings. So your quadriceps help you do knee extension, which is straightening your leg or straightening your knee. The hamstrings help you do knee flexion, which is bending your knee. And so having a good balance on those muscles really helps protect the knee and puts less strain on the ligament. I'm, again, a big basketball fan. Not that I love the Golden State Warriors, but I do think Klay Thompson's a really good player, if you guys know who he is. He tore his ACL last year. And I was talking with a sports medicine partner at my clinic last year, right after it happened. And before Klay Thompson tore his ACL, which is one of those main knee ligaments, he had pulled a hamstring. And we had this discussion of like, if you pull a hamstring, does it guarantee you're going to tear your ACL? No, absolutely not. But does it put you more at risk? And especially if you watch that video, how he fell right before he tore his ACL, it does really make you wonder, if he didn't have a pulled hamstring in that particular scenario, would he have torn his ACL? So those are the main muscles around the knee that are really important to balance front to back, hamstrings versus quads. I've seen a lot of guys, like people who are in love with the leg press machine but don't want to do the hamstring lifts. They'll be like really quad dominant versus hamstring dominant. So it's important to balance out both sides. Engaging muscles. Is it possible to get an image of the rectus abdominis with pyramidalis intact? It would be for a blog post. I'm willing to pay for the image. Well, engaging muscles, if we have a cadaver with a pyramidalis, that would be one thing. Pyramidalis, the reason I kind of posted this rather than just told you to DM us, is Pyramidalis is a variable muscle. It's one of the few variable muscles that not every cadaver has. And we're still doing a couple of dissections. And so if we find one, then that's definitely something we could engage with. So find us on Instagram and send us a DM, and we can kind of talk about that and when we do some future dissections. For those who don't know the pyramidalis, it's a small little muscle below your rectus abdominis, and it's a variable muscle. Not everybody has it. And there's a couple of those variable muscles. We've done some TikToks and some Instagrams on some ones that are in the wrist that not everybody has. So really interesting stuff. Hello from Germany. Hello from United States, Utah. BTS lover. Do you know anything about scoliosis? I was diagnosed with that in 8th grade. I do get pain now and then. And why does my body itch so much? The itch so much, I can't really answer unless you're wondering if that's related to scoliosis. Typically, that's not related to scoliosis. We don't have any cadavers that have scoliosis. We have one that has kyphosis, which is kind of a humpback. Scoliosis is more common in women, and especially in teenage girls. We do a lot of screening for that. When I was doing pediatrics rotations in school and all the well child exams with the teenage girls, we would have them do flexion of the lumbar spine, and we'd palpate the whole spine to see if there was anything obvious that was a lateral curve. So for those who don't know, scoliosis is this lateral curve, and there can be mild scoliosis all the way up to where people need like surgical correction of it. And we go from stages. I think we break them down from 0 to 20 degrees of a curve, from 20 to 40 degrees of a curve. You're going to get braced. Anything above that, they talk about surgery. And the thing is we typically, most of our cadavers are elderly. It doesn't mean we couldn't find a particular body that had scoliosis. It's just at this point we haven't had any cadavers with that specific spinal curvature. How are nerves linked up to muscles? Do they run through the muscles or what? So what happens is the nerves come out of the spinal, or at least they are branches from the spinal cord. And you have a spinal nerve at each level, like C1, C2, C3, C4, all the way down the spinal column. And the nerves tend to, especially for the limbs, they tend to form these combinations of nerves called plexuses. Like the brachial plexus is a big nerve plexus that goes down through the arm. And what's crazy to think about that is these nerves just start branching and branching and getting smaller and smaller and smaller and smaller until they get to their targets. Now, from the naked eye, if you were to look at a nerve going into the biceps, it would look like it was directly attaching to it. And yes, the connective tissues that are around the nerve tube, because the nerves are tubular structures, will attach to surrounding connective tissues of the muscles and other surrounding tissues to kind of hold them in place. But as it gets smaller and smaller and smaller and smaller, you start getting down to the neuron level. The neurons, technically, the axon terminal of the neuron just gets really close to the muscle cell, and then it releases its neurotransmitters in the neuromuscular junction. And so that part of the neuron doesn't technically touch the muscle cell. It gets really, really close. But the connective tissues of the nerves, before it actually releases its neurotransmitters onto the microscopic areas of the muscle cell that you can't see with the naked eye, those, when you're dissecting through a cadaver, you can see are attaching to kind of hold the bigger nerve in place as it's getting smaller and smaller and penetrating deeper into the muscle tissue. Sundara, what happens to the muscles of a morbidly obese person? That depends. If the more like somebody is who is morbidly obese, if they're still moving, the muscles can maintain relatively large sizes because they still are moving the body. When we get bodies from certain body donor programs, that is a discussion we've actually had as far as some individuals who are a little bit heavier, but were still known to be walking around and things like that, can have pretty good sized leg muscles. And so that is a huge factor. If they are not moving at all, then the muscles will start to atrophy. But say they're still walking and moving that body weight, especially the leg muscles, if you were to remove the adipose underneath and see the muscles, they would be sometimes in some cases bigger than somebody who wasn't morbidly obese in that case. So there's a lot of factors that will depend on that. Inactivity, in general, the muscles will start to get smaller. Muscles are these tissues that are use it or lose it tissues. Your body, muscle tissue is expensive, everyone. And what I mean by expensive is it takes a lot of resources to maintain it. There were not very many Arnold Schwarzeneggers and Lou Ferrignos back in the day when we didn't have all this access to food and things like that, because to maintain that much muscle tissue as these bodybuilders, for example, tons of calories, tons of resources, and the muscle tissue needs lots of protein, needs tons of calories to maintain the ability to contract. And so your body's kind of like, hey, if you're not going to use me, I'm not going to dedicate all these resources to maintaining this expensive tissue. Robin Essek, I think is how you pronounce that. So is the TENS unit that causes your muscles to contract similar to what occurs when you, say, lift weights? What are the physiological differences? There's some definite similarities to that, the contraction of a TENS unit. You can't, because you're just putting this stimulus on the surface and it starts to contract and contract. I don't think you definitely don't get the same benefits of increased blood flow. Now, when a muscle contracts, you're going to increase blood flow, but the full range of motion that you create in a joint from, say, doing a curl versus if you just place that on there and say, stimulate my biceps, is not going to be quite as great as, say, okay, now I've done full range of motion in this joint. I'm getting movement involved. That's going to create an increase in blood flow comparatively to the TENS. It would increase some blood flow, the TENS unit. Also, the range of motion that you're going to get with joint health, and taking the muscle through full range of motion in exercise has always shown to have good benefits as opposed to doing like halfsies. You know, like the purist bodybuilders, like they get after everybody if they don't do like a full range of motion squat versus like quarter squats. It doesn't mean you can't get benefits from doing partial range of motion movements. But to take a muscle through the full range of motion of where it can go eccentrically, concentrically through its full length, you can't stimulate that with a TENS unit. And I always tell people, like, let me give you an analogy. I taught at a massage school for years and years. I'm not a massage therapist, but a geeky anatomist. Loved the massage world and teaching anatomy there. One of the benefits of the massage, they'll say, we stimulate blood flow to the areas when we're massaging. And that's absolutely true, it is. But I always told my massage students to be careful not to like overdo that benefit. Like, that's the biggest, awesomest benefit on planet Earth. There's no way you're going to stimulate blood flow as well as somebody doing a full workout on that same muscle. Yes, you'll increase blood flow over baseline with a massage. You're still not going to do it as much as taking somebody through the whole range of motion. I love how happy you guys are about this stuff. We just got to post that on there while I'm scrolling through. Thanks, Aubrey. I appreciate that. Jerwin Lajara, I'm sorry if I don't say your guys' names correctly. How much muscle is too much muscle, like in bodybuilding, or is there such a thing? I think the verdict is still out a little bit on that. For the most part, no. If you're maintaining a healthy diet and you're exercising well and you're not overtraining, it's hard to draw a line where there'd be too much muscle. And, you know, there's some people who might argue, would that be too hard on your heart? I don't think so. Throughout the day, especially say somebody's a huge bodybuilder and the majority of their day, their blood pressure's within normal limits, their heart rate's within normal limits, I don't see why that would be too hard on their heart, especially, like I said, blood pressure's fine. They have a resting heart rate of like 55 or 60. To me, that would be the only concern there. Now, that's a little different than the wear and tear of training. So if you just take aside, I have X amount of muscle tissue, is this bad for me? Not so much. It's more of like there are some people who go crazy, like power lifters, and it's awesome. But sometimes they'll pay the price in the end. Like if they've had, they've been squatting, they've been deadlifting, they have multiple injuries that have added up over time. Those are the things I get more concerned of. But that's a separate issue than just plain old having muscle tissue. It's just sometimes to get that muscle tissue, there was some bumps in the road of maybe they hurt a disc in their back or they hurt their knee or something like that. And sometimes people don't have major injuries, but over time, there's just some wear and tear on the joints. So that stuff is more concerning than, say, the actual idea of having too much muscle tissue. Joe, how does age affect the stem cells? I'm 57 and just had rotator cuff surgery. Does the ability to heal, repair, decrease at a certain rate? Joe, I'm not sure if you were talking about kind of how I was mentioning skeletal muscle tissue's ability to regenerate. from if they die. In the case of the rotator cuff, there's not a lot of skeletal muscle necrosis in that situation. There might be a little bit. That's typically more of the tendon of the muscle. And there's a difference that I always tell people between killing a muscle cell versus injuring or damaging a muscle cell. Muscle cells can heal from damage and injury, but if you fully kill it, that's a different story. So there's that line of where you hit like the point of no return. Now, in the case of the rotator cuff surgery and things like that, as we age, things get less efficient, blood supply, regeneration capabilities. And so I think the stem cell in this case doesn't totally apply, because if that's what you were talking about, because there's at least the stem cells I was referring to natural stem cells that your body has to potentially create a couple or a few more extra skeletal muscle cells that died. If you're talking about stem cell injections that people are getting from embryonic stem cells, those are a whole different ballgame. And the verdict is still out on those, how much those can stimulate healing, because the frustrating part for me is everybody's getting different types of stem cells, different doses. There's not consistency around that. And when I was involved in it a little bit, and when I was at an orthopedic clinic, I really was like, okay, the biggest problem with this is everybody's getting different sources of stem cells, the number of stem cells they're injecting. Again, if we're talking about these embryonic stem cells that you guys hear about people injecting in joints and stuff like that. But in general, to overall answer your question, is somebody in their 50s going to heal slower than somebody in their 20s and 30s? Yes. Do people in their 50s still heal well with proper physical therapy? Yeah. The timeline, are we talking like weeks versus days versus months? Again, that would even just depend on you, how healthy of a 50-year-old a person was or in their 50s. But it will heal on its own. And hopefully I clarified what I meant by those stem cells there. Okay. So we're running low on time. So it's really nice for you guys. Sometimes I think I'm going to get to the bottom of this. So, but the list goes on. What happens when you stand up and everything feels dizzy like you're going to pass out? Is this a valid question? Yeah, it's a valid question. It's anatomy and physiology. Justin and I, just side note you guys for these future live streams, Justin and I have toyed around with the idea of should we only answer muscle-related questions or whatever the theme of the live stream is, maybe. But too late, I'm going to answer this question. Typically what happens is you stand up too quickly and gravity has an effect on blood supply. And I always joke around and say that your brain's the princess organ of the body. You like cut oxygen off for like 2 little seconds and it freaks out like you're going to pass out. So typically you stand up too quickly and you're moving up, gravity's wanting to push the blood down. And if you don't get the blood to come up to your brain fast enough, you start to feel dizzy like you're going to pass out because your brain gets starved temporarily for even just a few seconds for oxygen and it freaks out and it's not happy about it. And so natural mechanisms, when you stand up from a sitting position, your heart rate actually goes up for a few seconds to kind of compensate for that, to help get blood flow up there. Now, some people's reflex, internal reflex that you can't control, may not be as effective as other people. Some people are more prone to having that. All of us have had that moment where we stand up too quickly and we get a little dizzy and lightheaded and hopefully don't fully lose consciousness. If you're dehydrated, you're more likely to get it because your blood volume is a little lower when you're dehydrated. Well, it can be significantly lower if you're really dehydrated. If you tend to run low on blood pressure, if your blood pressure is kind of low normal, if you're one of those people, then you might be a little bit more prone to it. And so I have a couple patients who run their blood pressure's 100 over 60 something. And they've come in and I feel lightheaded sometimes when I stand up. I'm like, does it go away really quickly? And they're like, yeah. And usually it's just because they tend to run a little bit lower than normal, than the average person. You always hear 120 over 80. And I just say, okay, just make sure you're hydrated. Sometimes you might need to be careful and stand up a little more slowly during those instances when, you might be a little more prone to passing out. Okay. We're going to continue on here. So what happens? I kind of like this one because it's kind of the opposite. Saint Nico, what would happen to your muscles if you would eat a bleep ton of protein? I don't know if YouTube would get mad at me for saying that out loud. Would your body really use them up or not? Excess protein, there's a couple of things that happens with excess protein. Your kidneys deal with it and you get rid of it. You also can convert it to other things. It can get converted to fat. It takes, your liver can do a lot of conversions with protein. It can be used as energy in some cases, but some people worry about like the kidneys, like if you have too much protein. I don't really worry about it too much. Usually the liver does a good job converting it or using it for other things. But most people get enough protein in their diet for the most part. Athletes and bodybuilders and people who are strength training tend to be much more concerned about that. Okay. So Christina Lincoln, how do you get into this type of work? What degree do you have? To do this portion of my career, there's a lot of different routes to get here to teach anatomy, to do something like this. Now, for my medical portion, working in urgent care, I obviously went to a medical program in the Bay Area of California and got an MPA and work with patients in that area. And I love doing both of these things because the anatomy and physiology and the teaching just meshes so perfectly with patients and patient education and vice versa. I can bring what I learned in the clinic into the classroom of this. So if you're just talking about being a teacher, then it depends what level you want to go at. Like we're housed in a facility here where high school students actually bus in, and that's pretty amazing. It's awesome for us to see the high school students come through here. And the teachers bring them in, and so those teachers have a bachelor's degree and they teach anatomy. Now, most high schools, these kids here are really lucky and have a unique scenario because there's literally a cadaver lab on the fourth floor that they have access to. And so in that case, if you're teaching in high school, you can have a bachelor's degree. Now there's a lot of high school teachers that also have a master's degree. To teach at the community college level, it's typically a minimum bachelor's degree. A lot of times it's a master's degree. The rule of thumb that I was kind of taught is that you usually want to have a degree above the degree that you're teaching, if that makes sense. And so some colleges require PhDs for certain things. I personally, don't get mad at me if you have a PhD because PhDs are great. Don't think that just because you have certain letters behind your name makes you a great teacher. It typically means that you've met certain standards to have a certain knowledge base, which is great and it's awesome. I don't want to take away from that, so I have to be careful what I mean by that. But I have plenty of PhD teachers that sucked. I had plenty of PhD teachers that were great. I had teachers that just had master's degrees that were awesome and vice versa. So maybe I'm getting a little bit of a soapbox there, but there's a lot of different routes to teaching anatomy and physiology and pathology. Moving right along here. This is a great question. We're running out of time, you guys. I'm sorry. I wish we had more time to do this. And so, why is calcium so important? So, if you're talking about muscle contractions, calcium is so important because calcium, what it does is it binds to this protein called troponin tropomyosin, or two proteins, but we call it the TTC, the troponin tropomyosin complex. And what happens when a muscle's at rest, this protein called TTC blocks one of the contractile proteins. So it's at rest. It's called actin. It blocks actin. And when calcium gets released into the muscle cell, it moves this protein out of the way and immediately allows for contraction of the muscle. And I keep doing this because I'm like mimicking these myosin heads that ratchet on the actin and make the whole muscle cell contract. And I think we just need to do a really cool graphic muscle physiology video that we can edit and do some cool things with so you guys can see how those muscle contractions will work. But calcium is really important for initiating that muscle contraction to get this protein out of the way. And when calcium is removed from the muscle cell, it blocks the contractile protein again. Okay. So we've got time for a couple more questions, you guys. I just want to say this. I want to apologize. There's there's so many questions here, and literally I'm like scrolling like this, and sometimes I think I miss some, and sometimes I don't miss some. And if I do, you're more than welcome to post on our YouTube. What am I trying to say? There's like a post area on our YouTube channel page that you can do. You can also hit us up on Instagram and see if we can answer that there. So again, here's this question. It already dropped off. Let me add this again. Does stretching have an effect on the fast twitch and slow twitch muscle fibers? If so, is there a difference between the two? So in general, no. And I need to qualify that. Overall, if you maintain flexibility and say you were to stretch and get more flexible, there's some people who have said that you're going to lose explosive power if you stretch too much or you're too flexible. And then you watch somebody in ballet and you see how powerful and explosive they are when they jump. You see martial artists who can do the splits and the power they create from some of their aerial kicks and their roundhouses, and the amount of explosive power that they get in their fast twitch muscle fibers. Definitely. So that's more of, I don't think it affects the slow twitch at all, really. And I think it's a great thing to do after any form of exercise for maintaining mobility, flexibility. There's a company called Move Method that we partner with, by the way, that does a lot of stretching if you guys want to check them out, and a lot of stretch programs for dancers, for people that, anyway, you can check them out. And so back to that whole idea, when you have explosion in explosive strength, even in people who have really great flexibility and mobility, that you kind of don't even, in my mind, there's some things that we need to research and other things that we don't. And, well, I shouldn't say that we don't, but sometimes that you just look and you're like, that person's maintaining their explosive strength and their fast twitch muscle fibers, even though they're mobile and flexible. And I've seen sprinters who are really way more flexible than I am and explosive athletes. So short answer is no, but there's this one thing. If you were to do passive stretching prior to an explosive activity, say like you're doing, and there's some range of motion exercises that are going to be okay, but if you say you did like a 15-minute slow, deep breathing, passive stretching prior to an explosive activity, that has been shown to kind of inhibit explosive strength through fast twitch muscle fibers in the short term, just initially for that, say, that exercise. And so that's why one of the reasons they don't recommend passive slow stretching prior to, say, sprinting or an athletic event. It's more dynamic warm-ups that they look to, and then the more slow passive stretching to do. It's more of an effect on the nervous system. It's kind of like the nervous system gets ramped down a little bit. And part of what makes things explosive with muscle contractions is how fast the impulse can be sent through the nervous system. And if you kind of suppress that with slow, passive, relaxed stretching, it could inhibit in the short term, or say like at the beginning of the athletic event. And so that's why they don't recommend it in that case. But overall, having flexibility, no. So you guys, there's so many things I wish I could get to. So we're going to keep doing all these, you guys. We really appreciate your requests. Thanks for joining. Thanks for all of your questions. And we're going to have to cut here. Unfortunately, I went 5 minutes after, and I got to go teach a yoga anatomy. I thought about doing that. We're going to do a yoga anatomy live stream here, because we go teach it. I don't do like teach the yoga class, but teach anatomy of yoga. So unfortunately, I've got to go do that, and I can't spend much more time doing the live stream past our hour. And so again, thank you guys. Keep an eye out for more videos to drop. We're going to drop a couple more this next week, especially if Justin can negotiate his stuff with YouTube. We have faith in him. So you guys have a great day, and we'll see you next week.